What many of you are doing are innovating at the clinical interface, innovating at a management level, but there's also innovation which patients want, which is the translation of research. We spend a lot of money on research, fundamental research, wet lab research, and the frustration of many is that where do we see the fruits of that translating into care? And somebody who's utterly committed to actually putting the fruits of research into practice is Professor Robyn Ward. Robyn is Professor of Medicine at the University of New South Wales, an oncologist, and somebody who is a major researcher in her own right, but also chairs one of the more important Commonwealth committees which decide on whether or not there's an evidence base behind the services that we fund. Could you please welcome Robyn Ward?
Thank you, Norman. I too would like to acknowledge the traditional owners of the land on which we are having this conference. I would like to also thank Minister Skinner and Minister Humphries for the invitation to participate in this session today. As you've already heard, I'm a clinician. For the last 25 years, I've been a clinician in public hospitals in New South Wales. Over the last 2 weeks, I've been on call, and that's given me an opportunity to catch up with a lot of my healthcare professional colleagues that I don't normally see on a day-to-day basis. And that experience always reminds me of what a great health system Australia has, how we're able to deal with such complex healthcare needs of our patients 24 hours a day, 7 days a week. But at the same time, I feel a real sense of frustration with the healthcare system, for it can be so wasteful. And what I mean here is wasted opportunities to make things better. For the last 25 years, I've also led a double life. Not only have I been a clinician, but I've been a card-carrying cancer researcher. This has been a double life because in the world of internationally competitive, peer-reviewed research and clinical medicine aren't easy bedfellows. The reason for this is that research is often about the minutiae, about knowing more and more about less and less, about protecting ideas rather than connecting those ideas to people who could make something of them, people like the people in this audience. So having shared with 1,000 anonymous people some of the greatest frustrations of my two professional worlds, I wanted to spend the next little while talking to you about how innovation can overcome those problems of waste, inefficiency, and lack of connectedness. I'm going to tell you some stories about innovation and how the actions of individuals has made the difference. And then I'm going to ask you to make a difference. I'm going to ask you, the next time you have a chance to open a door to something new, then do it. Make something happen. One of my favourite books is a book called Helicobacter Pioneers. It's edited by Barry Marshall, one of Australia's Nobel laureates. There's a couple of reasons why I like this book. One is when I was a medical student, I was taught the maxim, no acid, no ulcer, meaning that acid was the cause of ulcers. When I was an intern, on my first night in ED, I was given a pair of galoshes to keep my feet dry as we were met with people vomiting litres of blood from their bleeding peptic ulcers. Between cases, we used to dine on pizzas provided to us by the pharmaceutical companies that sold cimetidine and ranitidine, the drugs that stopped the acid. And then miraculously, over a couple of years, it all stopped through an apparent stroke of genius. Ulcers were caused by an infection, and antibiotics were the treatment. But when you look back through the Helicobacter story, you can see that that idea had been there for ages. In fact, at least 10 people had the idea. One of them was the Greek general practitioner John Locutus, who himself had peptic ulcer disease. And in 1958, when he was bleeding from an attack of hemorrhagic gastritis, he treated himself with antibiotics. He had very logically reasoned about the link between infections and peptic ulcers. He went on to cure thousands of people from peptic ulcer disease using his homemade brew of antibiotics called eviQ. His views were ignored by the authorities, they were ignored by the medical establishment, and his attempts to publish his findings were quashed. Eventually, he was persecuted by those groups, and he died a tormented man. The story of Helicobacter and Locutus shows us that new ideas rarely come as eureka moments, but rather they slowly gather life over a long period of time. I think the take-home message from the Helicobacter story is really less about the genius of Warren and Marshall and much more about the power of systems and people to obstruct and stifle innovation, and also, of course, to bring those innovations to life. Great ideas eventually get traction, but the power of the people who sit in this audience is to make that happen faster. Sometimes the very best thing you can do is to take a chance and get out of the road. You might be sitting there thinking that it's all very easy to recognise bright ideas with the aid of hindsight, but it's much harder to pick them up ahead of time. I agree. But innovation is not just about coming up with bright ideas or even recognising those ideas. 90% of innovation is about putting into practice the things we already know or can easily see need to be done. That is, making it happen. With this in mind, I wanted to talk about innovations that are at a scale way below that of Helicobacter pylori, and tell you two of my own stories, which I hope illustrates the power of people and the system to foster innovation. My first story is about hereditary colorectal cancer, about a particular form of this disease called Lynch syndrome. Lynch syndrome was discovered more than 100 years ago. In 1993, the genes that cause Lynch syndrome were discovered. And for over a decade, we've been testing patients to see if they have the particular mutation, which means they have Lynch syndrome. DNA testing makes a remarkable difference to patients' lives. They're able to implement strategies which would dramatically reduce their risk of dying of colorectal cancer, just in the same way as Angelina Jolie found out she had the breast cancer genes and decided to have prophylactic mastectomies. So it's great if you can find an abnormal gene, but some people appear to have Lynch syndrome, but the DNA testing is normal. In 2004, my research team made an important finding about this group of people. We found that a gene in their DNA was in fact paralysed by a chemical modification, which meant that the gene stopped working. So the spelling of the gene was normal, but it still didn't work properly, and that was the reason these people had Lynch syndrome. We called this an epimutation. For the scientists involved in this work, this has been very rewarding. We've had publications, invitations to speak, and grants. But much more importantly, this work has had patient impact because this information was picked up by family cancer clinics all over the world, and patients are now tested for epimutations. But the main reason I wanted to tell you about this story is to tell you that this work could only have happened because of people in the healthcare system. People like Rachel, a genetics counsellor. Rachel came in on weekends to meet the patient and the family. Like a dog at a bone, she tracked down medical records that were ostensibly lost. She found tumour samples from patients, and she brought blood samples over to the laboratory. Why did Rachel take this extraordinary step? I think Rachel let herself be excited by the idea, by the possibility that what we were doing was important. In many ways, what Rachel did were very little things, but they made all the difference, because without her actions, none of the scientific work could ever have happened. My second story is about a program called eviQ. eviQ is a web-based point-of-care cancer treatment resource system that I started in 2001. The reason I started eviQ was because it was clear that the technology of the internet could solve a terrible inefficiency that had been part of my professional life for years. So what was that inefficiency? Well, the instructions for all cancer treatments that were being administered by doctors and nurses at all our hospitals came from bits of paper stored in filing cabinets or in the forgetful minds of our senior doctors. Sometimes this information was kept in protocol books, which were invariably out of date and often wrong. Even if a hospital had a protocol book, the one thing you could guarantee was that their version of the chemotherapy treatment was different from the version in the next hospital or even the next department. Let me be clear here, the treatments should have been the same. Over the next 13 years, eviQ grew to be the gold standard source of information about cancer treatments for Australian health professionals. Today it's hosted by the New South Wales Cancer Institute and covers medical oncology, haematology, cancer genetics, transplantation, radiation oncology and cancer nursing. It is used by 32,000 people in 140 countries. It has 1,500 content items and 7.5 million page views. The information on the site represents the collective, regular and unpaid input of 600 cancer clinical experts. So let me share with you why eviQ is alive and kicking today. In the beginning, a couple of people who had absolutely nothing to do with cancer were instrumental in getting eviQ off the ground. One was a senior IT person at St Vincent's Hospital. He gave me a server, software, and various permissions to stuff that I'm certain I wasn't supposed to see. Why did he do this? I think he knew that IT in hospitals were going to have to change, even if the rules at that time said it shouldn't. And he felt this was the best way to keep an eye on things, and probably on me. Another key person was a hospital administrator who had been given money from New South Wales Health to buy a new fleet car for patients. I asked her to use the money to pay for a part-time pharmacist a couple of days a week as a second pair of eyes to check the drugs I was entering into eviQ. And so it was that the Corolla became the salary of the part-time pharmacist. Why did the administrator take the personal responsibility of using money like this? I think because it was in her mind the potential reward made it worthwhile the risk she took. After a year or so, we moved eviQ from the intranet at St Vincent's Hospital to make it available at hospitals in southeast Sydney. Some of the clinicians at other hospitals were fantastic contributors, but some were highly critical of the entire enterprise. Mostly they felt that I was making oncology into a cookbook medicine and that patient outcomes would suffer as unauthorised healthcare professionals, and I think they meant surgeons, would start trying to treat people with drugs. Despite their fears, eviQ continued to grow, and as a consequence, the IT platform became unstable. Since there was no more money on offer for fleet cars, I visited others, including the CE of the New South Wales Cancer Council, and I asked him for $50,000 for an IT platform. The following week, he sent me a cheque for $50,000. Why? I think he was challenged by the idea that millions were being invested in research by his own organisation, yet for the sake of $50,000, this very practical tool, which could deliver the fruits of medical research, may never even get a chance. In 2004, I was searching for a new permanent home for eviQ, so I showed the site to Jim Bishop, who was then the Chief Cancer Officer. Fortunately, he agreed to take it over as part of the Cancer Institute. Why did he act? I think he was shocked to see the cold reality that clinicians were making avoidable mistakes in delivering cancer treatments because of something so simple as not having a shared place to write things down. In my mind, I think the key to the success of eviQ is its collaborative culture. Nearly 600 clinicians contribute to eviQ. They do this in lots of different ways, but one important way is through reference group meetings, where clinicians sit around a table for quite a few hours and really focus on the details and evidence for delivering patient care. A few weeks ago, I attended one of those reference group meetings. The people around the table were from all over Australia. There was no egos on display. They talked about their mistakes, they challenged each other, They had lots of great ideas for improving content and implementation of eviQ. In short, they were innovating. They knew the decisions they made had impact. It's in creating a culture like this where innovation bubbles to the fore. Australia is a small country, so 97% of new scientific knowledge will arise internationally. But as I have discussed today, innovation is not just about new scientific knowledge. It's all about making things happen, about taking what the world knows and making sure we use it. I've tried to show through a few examples that what makes the difference in the end is not the breakthrough discoveries and the grand research enterprises, but the cumulative actions of many people over a long period of time, each one of them doing their bit to make something happen. So for the people sitting in the audience, I'll end where I began and ask you, the very next time you can, to open a door or take the risk or the extra step. Because by doing that, you'll be letting someone's new idea grow up to be an innovation. Thank you.
Thanks, Robyn. The path to translation is long. 15 years from discovery there, and as you said, with Helicobacter even longer. Patients want it in 5 years, not 10. You know, when I interview researchers, they say, well, when's this going to happen? Oh, 10 or 15 years from now. Well, stuff that. How do we make it happen in 5? What does the system have to do to facilitate rapid acceptance of evidence?
I think it's partly about the culture of the system, being receptive to change and having the mechanisms that allow new things to be adopted quickly. I think the system is often Teflon coated in that when new things come along, the instant reaction is to say no and provide reasons why things can't happen, rather than, as I said in those stories, taking a chance and accepting some small risk to implement new things.
But we've been bullied into evidence-based medicine. I mean, eviQ's, we're not saying you're bullying, but so the Greek general practitioner with this intuition. And now if he'd come up and, in this day and age and said, I'm giving this cocktail of antibiotics, we say, this is a complete nutter. He's not done a randomized trial. We will banish him into the world of complementary medicine and mad stuff. How do you, I mean, and of course there's hundreds of people out there doing stuff that they believe is the right thing. How do you get through the noise?
It's very difficult to do that, simply in a reaction to something. But I think you go back to fundamental scientific principles, and if you look back even through the John Lakuta story, he wasn't mad. I mean, he had a very logical sequence of reasoning that went on. He passed the test of scientific skepticism. I mean, we can't throw out scientific skepticism. We have to provide scientific lens through which we look at everything. But I think in doing that, you see that you can adopt a lot more things than we currently do, and it finds a way for you to sort out the chaff from what is potentially real scientific advances.
So what's your advice for advocating for innovation? In a sense, you were lucky you were a senior doctor with the ears of people in power. But equally, it may be a staff nurse on the ward that comes up with the innovation who might not have the ear of the authorities, but still have something that's very effective.
I think the only way we're not going to lose those innovations that come up from, as you say, from junior people or from people who are not so empowered is to create a culture around them that allows those ideas to bubble up to the fore. And that was what I was talking about the culture of eviQ, in that it creates that opportunity for people to be much more honest and transparent about what they're doing, and to sort of say the silly things that they wouldn't dare say in a normal departmental meeting. So
you've got, let's take eviQ as an example. You've got eviQ out there. What innovation have you come up with to actually make oncologists and radiation oncologists do the right thing?
I think the key word not to use is make.
Okay.
You can't make doctors do anything, as I think everyone would agree. They're very resistant to being made to do anything. And I think the key to eviQ's success is really not making anyone do anything. It's involving them in actually producing what is which is available online and what their colleagues will use. And so we found often that the most empowering thing about eviQ was that the doctors who didn't have a voice, the no key opinion leaders, but the doctors who were more junior, it gave them a voice, and a lot of them had a lot of very, very good things to say and contribute.
You alluded to your reference group and so on. What's the role of consumers in innovation? Because they could be put at risk by innovation, because it could be a risky innovation, but also they could push innovation.
Consumers certainly can push innovation. I mean, that consumers can be put at risk by innovation, but the same token, I would argue that consumers miss out on a lot of important improvements that could be made to their care by not being allowed to be exposed to innovation. And I mean innovation as little as things that are happening in a ward to big innovation. So I don't think innovation is just a loss to consumers. It's a loss if they don't actually get exposed to it. I think innovation, consumers have a role in honing down the questions that mean something to them. So they have a much better sense often of actually saying, well, really what matters to me at this point is actually my quality of life. It doesn't matter whether I live any longer. I just want that life to be good. I mean, they often actually hit the nail on the head when they're telling you about what is really important to them. And if we have a mechanism for allowing researchers to actually respond to that, rather than necessarily doing what they find as interesting, then we might get a more responsive research workforce.
Robyn, thank you.
Thank you.